So coming up first, we have Dr. Larry Elmer, who's going to talk today about non-motor complications of Parkinson's disease. He's with the University of Toledo College of Medicine. That is the home of the Gardner McMaster Parkinson Center and Advanced...
You don't need to read that stuff.
Okay.
That's a waste of time.
All right. The one thing I will say is that unfortunately he can't stay with us for the full presentation today. So we are going to do a quick question and answer with him at the end of his presentation, and he has another obligation later today. So without further ado.
Thank you. Thank you so much.
Thank you.
Is this on? Are we on? Can you hear me? Can you hear me? Okay, I don't do well behind podiums. And I cannot tell you how grateful I am to Pat and Chris and the entire movement disorder team here inviting me back to see you. This is one of the greatest support groups in the nation, and I have the honor of speaking at a lot of different support groups, and you all have a fantastic, fantastic program here. And I do believe so much of that credit belongs to these two people right here, so I'd like to give them another round of applause. Okay. First off, I have been here a couple times, and I just wondered, how many of you who have been here, or anybody in here ever seen me talk here before? You raise your hands. Oh, good, not too many. So I can use all my old stupid jokes, and they'll probably work on most of you. All right, that's great. Okay, well listen, we got a lot to do. We've got a lot to do in a very short period of time, because I'm gonna try and finish up by 10 p.m. There you go. See, I'm not even sure what time zone I'm in anymore. It's crazy. The travel has just been crazy. I'm going to try and finish up by 10 a.m. So we've got about 15 minutes for Q&A after that. And I do really appreciate you all allowing me to come, speak, and then get out of here. I literally have been away from home probably more in the last 3 weeks than I've been home. So, so I do truly appreciate that. But what I want to do first is we're going to talk about just the quote-unquote motor part of this, just to make sure we're all on the same page. Because if you don't know the motor, it's hard then to really describe and explain the non-motor. And this concept of non-motor is relatively new in our world of movement disorders. And I'll try to explain when that came about. But non-motor is now starting to be, non-motor and pre-motor are now starting to be some of the symptoms of Parkinson's that we recognize that are really part of the disease, and in some cases are more difficult to deal with than the classic symptoms of the stiffness, slowness, and shakiness. So we're going to spend just a little bit of time sort of putting the motor in perspective, and then we're going to dig into the non-motor. And I'm afraid I'm going to have a lot of information for you, and I'm going to try to get through it as quickly as possible, but hopefully we can have a good time of Q&A. Is there anybody in here who remembers the one medicine that I told you should put on your list of allergies? What's that? Haldol? Yeah, Haldol. Okay, we're going to talk about that. Good, I'm glad somebody's there. Okay, so we cannot ignore the fact that last year was the 200th anniversary of James Parkinson's monograph. He wrote as a surgeon in London, working out of his second floor villa, whatever it was, looking down on the streets, seeing people walk by, and some of them would walk by, and they'd have a little bit of shaking. And then the next year they'd walk by and they'd have shaking on both sides, and maybe they were a little stooped over. And then the next year they'd be walking along and they'd be kind of taking these little shuffling steps and shaking. Through his observations, we receive the description of Parkinson's disease. And what's most important, I think, from our standpoint is he was always looking to the future. And he said, on the contrary, there appears to be sufficient reason for hoping that some remedial process may ere long be discovered by which at least the progress of the disease may be stopped. That means that one day we will have treatments that will either prevent Parkinson's, or if you're diagnosed with Parkinson's, will stop it from progressing. And unfortunately, I didn't get these gray hairs for nothing. I've been living through all those 5-year epics. You know how they always say something like, oh, the cure is just 5 years around the corner. 5 years, that's all we need, is just another 5 years and we're gonna figure this out. I've seen so many 5 years come and go. I am damn sick and tired of seeing them come and go. And yet, here we are, and I can tell you unequivocally, there is research being done right now. There's another area of movement disorders called Huntington's disease. It's kind of the opposite of Parkinson's. Instead of being sporadic, it's inherited. Instead of being too little movement, it's too much movement. There are treatments right now that have demonstrated not just an arrest of the disease, but also an improvement in brain function, reversing some of the damage. And the principles that are being applied in that disease can also be applied to this disease. So I think we are closer than ever. But I'm not going to say 5 years. I'm just going to say it looks, at this point, I believe it might happen in my lifetime. And I got to tell you, if we find a way to either arrest, stop Parkinson's in its tracks, or, as I'll mention, premotor, diagnose people who are en route to developing Parkinson's, are not there, but they're in the process of developing it. And we can give them something that will actually prevent them from ever getting Parkinson's. I will die with the hugest smile on my face. It's going to be something like this. Of course, my eyes will be closed because otherwise it'll be really weird looking in the casket, you know. I mean, it'll be kind of like this. So, the bottom line is, I gotta tell you, the breakthroughs are just coming at such a rapid pace. It's really crazy. I just gave a talk yesterday to a group of nursing faculty, and I shared with them some of the studies that are being done. And although a lot of studies have been done to slow the disease and, you know, try to provide disease modification or, you know, neuroprotection, whatever, and a lot of them have failed, we have not yet begun to treat Parkinson's prior to its diagnosis. We're still kind of behind the 8 ball when it comes to that. And hopefully I can explain that a little bit. So, okay, I got to remember, I only have a couple hours here, so. Okay, so let's talk about what are the classic signs and symptoms of Parkinson's. You're all familiar with these because you're living with these. Everybody's different. Everybody has different symptoms. Everybody has different side effects from medicines. Everybody has different benefit from the medications. But the stooped posture, the small handwriting, decreased arm swing, typically more on the one side that it started, changes in facial expression, lack of that animation that we all normally have, soft voice, difficulty getting up out of a chair, shuffling gait, all those things are classic symptoms. But there are some other symptoms that are far more challenging than the classic symptoms of Parkinson's, and that is now added to the list. Falling, freezing, orthostatic hypotension, which means basically when you stand up, your blood pressure drops and you feel lightheaded, and sometimes you even pass out. Anybody in here ever stood up real fast and passed out because of their Parkinson's or with Parkinson's? Anybody have that trouble? Yep, yep, see those hands going up? Sleep disorders, oh my gosh. So many changes in our sleep patterns with Parkinson's, and unfortunately also as we get older. dementia, psychosis, sexual bladder dysfunction, the list just goes on and on and on. And I wanted just to bring you up to date why we're at the point we are right now. And quite honestly, when this young man, Dr. Guttuso, I think he was in kindergarten at this time. Yep. And basically, we were sitting in this conference room in Berlin because a series of events had happened. They found a gene that caused Parkinson's in this family over near Italy and Greece. And then they found a way to identify the protein that was made by that gene. Because remember, we're all made up of our DNA, right? That's what we inherit from our parents. And DNA goes to RNA, goes to protein. And protein is really what most of us are made of, except for some of us who are a little overweight, and that means we're made up of fat mostly. But protein is the key part of what our cells use to do what they do. And alpha-synuclein was the protein that was identified as being the problem in Parkinson's. It misfolded, and then it started to glump together. And in 2003, this paper right here, and the presentation literally, like I said, I think Tom was probably, he might have been in first grade, I'm not sure, but anyway, so young, so young. That was 15 years ago. And for years and years, we tried, we struggled, we wrestled with the whole idea. Why is it that this one group of nerve cells in the back of our brain, the so-called substantia nigra, anybody heard about the substantia nigra before? Can I see a show of hands? Okay, substantia nigra is a group of nerve cells in our brain. It's actually part of the brain stem. Substantia means body, nigra means black. Literally, if you cut the brain in a certain way, you see this. It's the same color that's in our moles. I've got one right here, but I didn't want to rip my shirt off. But it's really dark. It's really dark. And so that melanin is in those cells, but those cells are the ones that make the dopamine, and then they send it up to the front of the brain or the middle of the brain. And we always thought, why are these cells so susceptible? Why do they die off so rapidly? Well, Dr. Brock and colleagues showed us that it wasn't those nerve cells that died off so rapidly. In fact, the two areas that were first affected by Parkinson's were two completely unexpected and unusual places. Where our sense of smell is located, what's called the olfactory bulb, and the nervous system of our intestines. Now, why is that important? Why would those nerve cells be so vulnerable to the abnormal folding of this protein called alpha-synuclein? What distinguishes those nerve cells? Any guesses? Guesses? Nerve cells in your sense of smell. Nerve cells in your intestines. Food. Where does food come from? Outside, right? Everything you eat and drink comes from the external environment. That is the place the external environment is exposed to your nervous system. Every breath you take, unless you go like this, when you're smelling, when you're breathing through your nose, every bit of air goes over the surface of the olfactory bulb. So when Dr. Brock published that, you could hear a pin drop in a room of probably 3,000 movement disorder specialists. Because now we realized the answer was there. And that has led to an incredible explosion of knowledge in terms of what we understand about Parkinson's, how we can identify it, and most importantly, how we can identify it before people ever get Parkinson's, because the way the brain works, the way this disease works, is it goes from the intestines up to the very base of the brain, called the medulla. Now, here's a question. How many of you with Parkinson's have noticed that you have trouble with your sense of smell? All right, that's a fair number of you. All right, now, those of you who are either spouses, caregivers, family members, whatever, of people who have Parkinson's, how many of you have noticed that your loved one with Parkinson's, when they're asleep and dreaming, they tend to either talk all the time, or they thrash around, or they do all kinds of things? Any show of hands for that? Okay, that's the other half of the audience. Okay, well, I guess we're talking the same language, because you lost a sense of smell, and something called REM sleep behavior disorder, which I'm going to show you a video of. It ain't pretty. It ain't pretty. You're acting out your dreams. Normally when we're asleep, our muscles are paralyzed. That's why when you wake up and you're trying to get away from somebody, you're just like, oh, I can't move, I can't move. But in Parkinson's, that switch is damaged. So you do move. And if you're fishing in your dream, you're going like this. And you can do a lot of things in your dreams that, can get you into trouble. So I'm just saying. We do have a treatment for that. Thank goodness. Okay. So basically, this pathology, this misfolded alpha-synuclein moves from these two locations, gets into the base of the brain, and then starts its steady march right up the brain stem. And in stage 4 of Brock's 6 stages, this isn't even halfway. This is past halfway. Stage 4, the substantia nigra gets hit by this wave, this tsunami of damage that is marching its way up through the brainstem. And we believe now that that's really the case in the majority. Not everybody with Parkinson's has this type of pathology, but probably the majority. And in a sense, the substantia nigra is no different from the rest of the brain. Everything gets damaged along the way. That's why we have premotor and non-motor complications, because it's not just about mobility. The substantia nigra was mostly about mobility. So then it keeps going up and can eventually hit the top of the brain when it affects your thinking. And we're going to talk about that, because I've got good news and bad news about that. The good news is that we have really good treatments for problems in thinking with Parkinson's. The bad news is they don't work all the time. And that's the problem with all of you. I haven't seen a single white rat among you. There's nobody out there with pink ears and a little fuzzy nose and whiskers and a long pink tail. You're all different, every single one of you. And our diagnostic skills, our ability to treat you, your response to the medication, the side effects, etc., I alluded to this earlier, is different in everybody. But the great news is that the number of tools that we have in our toolbox is growing and growing and growing, so we can treat more and more and more of these problems successfully. Okay, so, all right, now I really got to put on the accelerator pedal. Okay, so basically, just in a nutshell, this is what we thought of Parkinson's. It was the tip of the iceberg. We thought it was all about stiffness, slowness, and shakiness. We didn't realize that there was a huge part of Parkinson's that was right underneath the surface. So we ran with our little speedboat and crashed right into that big old iceberg, because we were thinking Parkinson's was one thing when in reality it was a much bigger entity. It affects so many areas of our life, and I hope by the time I'm done talking you will appreciate how it can. Now, one thing I have to say, because I gave this talk in Columbus, And the first thing the leader of the group said when he got up there is, "Not all of you are going to get all of these symptoms and side effects." And I want to assure you, not all of you will, because you're all different. Some of you may not have any of these pre-motor or non-motor complications, but some of you will. And I'd rather tell you what you might get and hope that you don't get it, rather than have you uninformed and get something and not know what the heck's going on. Does that make sense? Is that fair? Okay. Okay, so now what we think about Parkinson's is we think about it as a lifetime continuum. Literally from the day you're born, from the day you're conceived, we are all, every single one of us has certain susceptibilities to different diseases, different like diabetes, high blood pressure, high cholesterol, and also to Parkinson's. The latest estimate is, well, there are genetic forms, there are inherited forms of Parkinson's, but they're extremely rare, and there's maybe like 20 or 30 of them. But the latest estimate on the number of genes in our DNA that make us susceptible to Parkinson's is about 100. And so, as you can imagine, that's why some families get it and some families don't. So it's quite the change. But what we're going to talk about today mostly is this pre-motor time, because this is the point right here, 0 days. That's when people are diagnosed with Parkinson's because they've got the classic symptoms. We're trying to figure out, can we diagnose it in this 10 to 15 year period before the Parkinson symptoms emerge? That's the real challenge, and I believe that's where the cure, if you will, because if we can identify people who are en route to developing Parkinson's before they develop it and we can stop that, then that's about as good as a cure we can get. Because you can't transplant the brain. In fact, if anybody offers to take your brain out and replace it with another one, absolutely refuse, because we're really good at taking them out. We have not had any success in putting them back in again. Yet. Maybe one day it'll happen, I don't know. Anyway, this is a hard slide to see, but just lists the groups all around the world that are studying these pre-motor symptoms, led by the Michael J. Fox Foundation, led by the PARS group over in Pennsylvania. I mean, all around the world, people are studying this. And ladies and gentlemen, I got to tell you, we are learning a lot. A lot happens to our nervous system, a lot happens to our bodies well before we get the symptoms of Parkinson's. And that, I think, will hold the key to being able to intervene way before any damage to the dopamine occurs. These are just a handful of things. If you would like to protect yourself against Parkinson's, well, drink a lot of coffee. You could even have some red wine every once in a while. I think it says alcohol. Caffeine and alcohol. Yeah, I haven't really heard about the alcohol thing, but I'm all for it. I mean, that sounds good to me, especially coffee with alcohol. I mean, that's really good. Okay, and then elevated urate. They're studying that right now. I don't know if that's going to pan out or not, but unfortunately, then it places you at risk of gout. I don't know if you'd want gout versus Parkinson's. Hard to say. Those of you who had gout, you know what I mean. And then smoking. Smoking has always been shown to reduce the risk of Parkinson's. However, we do not recommend people start smoking. I think most of those people probably just died before they got Parkinson's. I mean, that's just my suspicion. Oh, and so here are the other things. So what if these are the things that cause you to be at risk of developing Parkinson's? Constipation, depression, anxiety, anosmia, that's that lack of sense of smell. And then the REM behavior disorder, where you act out your dreams. Pesticide exposure, herbicide exposure. How many of you grew up on well water? How many of you are farmers or grew up on farms? Okay, so we know now, unfortunately, the pesticides and herbicides that we used years and years ago, they put us all at greater risk. Anybody who was exposed to that are at greater risk of developing Parkinson's. Okay, so what is it about Parkinson's? So we're gonna bring this motor thing to an end here. It's slowness. Brady means slow, kinesia means movement, and then you've got to have at least one other thing to make a clinical diagnosis. And here's a video of very, very old video when levodopa was very first introduced. This gentleman is not being treated right now. You can see the classic short shuffling steps that he has. He has no arm swing. He probably feels pretty rough because when you're in the off state, we call this the off state, when the dopamine is not working. When you're in the off state, you don't feel good. Your muscles are tight, they ache, and you have trouble getting around, just like this guy does. And then you can see him kind of, stutter step as he tries to turn around. That's called freezing or festinating gait. And then he, makes his way back. This is, like I said, this was decades and decades ago. So now he took his levodopa. Thank goodness levodopa is always packaged with carbidopa to prevent that nausea and vomiting, because most of these people, they would take their levodopa, go heave in the bathroom, and then come out 30 minutes later and look just like this guy. Walking about as normally as you could ever expect, just looking very, very normal. And that's what dopamine does. Dopamine takes you from being the Tin Man in The Wizard of Oz after he's been in the rainstorm, oil can, to dancing all over the place, completely well-oiled. I call dopamine the WD-40 of the brain. So where were we in 1960s? Levodopa was the king of the hill. It was the best thing ever invented for Parkinson's, but unfortunately it did have some complications. It went up and down in the bloodstream, and as a result, over years we started to notice that there were periods of time. So think about this dotted line as being a measure over years of the brain's ability to buffer dopamine. In a sense, it represents the continual loss of those substantia nigra neurons. The ability of those dopamine neurons to take up levodopa, convert it to dopamine, and release it in a timely fashion. Early on, you can see that those fluctuations in the blood level, which occur over a period of hours, you're fine. You're in that therapeutic window. You feel good. But unfortunately, as the disease progresses, then sometimes the medicine is a little too low and you can't hardly move and you feel pretty lousy. Or maybe you're too high, you've got too much in your system. You've got the wiggling movements, just like Michael J. Fox. And he started on levodopa. He had to. That's about all we had. He was 30 years old. So when he's on TV, he prefers to be in the wiggling state because he can express himself better. His voice is stronger. He can think better. But dyskinesia is one of those side effects. Now we've moved from a time where we had one tool in our toolbox. Basically, it was a hammer. And when all you got is a hammer, everything looks like a nail. You know that, right? You heard that before? Well, for us, now we have so many tools. It's like going to Sears and buying one of those big Craftsman, stand-up roll dollies, with all the tools in it. It's just like, oh my gosh, I got something for that. So, okay, but this is kind of the list. And it includes some of the newer ones, the Gocovri and the sulfonamide. This is Xadago. And then there's Duopa, this new pump. I think I showed you these briefly, but I got to keep going. Okay, so what is our goal? Well, our long-term goal, very, very simple, very, very difficult. Keep the dopamine levels the same all day long, if at all possible. Keep them the same. And number 2, prevent the further loss of those dopamine neurons. Keep that therapeutic window wide open. Simple task, challenging to accomplish. So now, just so that we all know the difference between off and on, I showed you the video of the man walking. Now this could be any one of us going to visit our neurologist. Now this neurologist, though, is a very special guy. His name is Rich Dewey. He's down in Dallas, Texas. And he can spot Parkinson's a mile away. But this guy's in a study, and we'll just call him Joe. And he's going through all these tests that Dr. Dewey's having him go through. I might have shown this video before, I can't remember. but he's a little slow. Well, you know, when you get older, you get slow, right? I mean, isn't that right? Don't we all get slower as we get old? You know, arthritis sets in. It's kind of hard to move. But this guy is not slow because of that. He's slow because he's got a lack of dopamine. And one of the areas that's most affected with him is his gait. So Dr. Dewey asks him to cross his arms, stand up, and walk a little bit. So he thinks about it for a second and gets up, you know, his inertia there, and he just, I got up. Okay, finally. And finally, when he stands up, you can finally see his tremor. Now, realize not everybody with Parkinson's is going to have a tremor. Probably a good 25-30% of people with Parkinson's will never have a rest tremor. But 98% of you will have bradykinesia, and 95% will have rigidity, what we call rigidity or stiffness. So this guy's actually in a study. He's in a study of a compound that is the closest equivalent that we've ever found to synthetic dopamine. It's called apomorphine. We don't use it that much because you have to use it, you know, like insulin. You've got to give an injection, and but they're developing one. There's one in development right now. It's just like the Listerine patch, or Listerine, what is it? Yeah, the breath thing, yeah. It's like that. You put it right underneath your tongue and it just kicks in just like that. And now you can see Slow Joe. He ain't slow no mo. He's pretty fast. So it wasn't that he was old or that he had arthritis. It was because his dopamine levels were low. His WD-40 was low. He was 2 quarts low in his crankcase. Does that sound reasonable? He was low. And now he's not. His dopamine levels are normal. Now, the problem with apomorphine is it doesn't last very long. We use it as a rescue medicine. It only lasts about an hour, hour and a half. But when it works pretty well. You can see this guy jump out of this chair, and now, instead of taking those short shuffling steps, he's ready to go out in the golf course. Probably on a beautiful day like this in Buffalo. I mean, you know, who could have asked for better weather on May 12th? I mean, gosh, it's just gorgeous out there. It's got to be at least 42 degrees and rainy. It's just a beautiful spring. Can't imagine anything better. So when people start to experience those ups and downs with their medicine, wearing off, turning on, wearing off, turning on, how do we treat that? Well, one way is just to give you more doses. Maybe cut the tablets in half and have you take them twice as often. Doesn't that sound like fun? Going from every 4 hours to every 2 hours. Oh boy, does that sound like fun. Well, that's supposed to be represented here, and you can see the big peaks and troughs, but then if you cut them in half, you get smaller peaks and troughs, so you get a more consistent response, but it's twice as often that you got to take that. So we're trying to figure out how in the world do we take care of this without causing people to go crazy trying to keep up with their medication. There's a lot of different reasons. The one I want to point out to you, though, is what's called gastroparesis. That's a fancy name for the fact that your stomach quits working. It doesn't squeeze the food into the intestines like it's supposed to. And if it doesn't squeeze food, it doesn't squeeze pills either. So you take your pills, and they can just sit there for minutes, hours, and you got to get that stomach moving. And unfortunately, there aren't too many good treatments for that. So we got one in Canada. I can't tell you about it because it's not FDA approved. It's called domperidone, but I didn't say that. Domperidone. I didn't say that. It rhymes with Dom Perignon, which is a very, very expensive champagne. But domperidone, probably the only safe treatment for gastroparesis and Parkinson's disease. And you can't get it from Canada. But if anybody ever asks you, where did you hear that? You say, oh, some guy at a conference. I heard some guy talk about this. I don't remember what his name was, though. I don't know. Okay, because that is so important in getting the medicine into your system. And it has accounted for a lot of people taking their first dose of the day and not turning on. not even getting that first dose to kick in. Because your stomach, if it just sits in your stomach, doesn't get in the intestines, it doesn't get absorbed. Okay, there are some new medicines. I'm just going to go through these briefly. This is Rytary. This was thought to, so basically this shows you sort of the absorption and then the decay of the regular forms of levodopa, both regular, CR, and Stalevo. But here's the Rytary thing, that long, extended duration. Now, this was very hard to use when it first came out. We've started using it in combination with short acting, so we give it about 3 times a day at 5-hour intervals about. So 1 tablet of short-acting Cinemet, 1 tablet or capsule of Rytary. That seems to work pretty well, but it is expensive. It depends on if your insurance covers it or not. There's another drug that's being used now for those intractable dyskinesias called Gocovri, and the way this works is basically you take it at night, it stays inert in your system for several hours and then slowly rises in your bloodstream until morning when you take your first dose. So if you have trouble with dyskinesias all day long, this is something you might want to look into. DBS is another option, obviously. And then finally, Xadago is one of the newer treatments. I just want to mention these because I know we've got sponsors out there. And so the bottom line is these are all just different tools in our toolbox, and sometimes people will benefit from them. Most people won't need them, quite honestly. Oh, and then the last one I have to mention is the Duopa pump. Now this requires surgical insertion of a tube into your stomach, and then another tube to get the stuff into your intestine, and then you carry around this little box that has this packet of carbidopa-levodopa gel. And now I showed you the absorption slide for the Rytary and those other medicines. Look at this. This is a 24-hour period of time. Basically, the blood levels of levodopa go up and stay up and stay up and stay up until you turn it off at night, and then they go down. So this is one of the very, very first treatments that we have that can deliver levodopa in a continuous fashion, yet thankfully most, if not almost all of our patients never even have to think about this. So, okay, so now I've got 4 minutes to cover the rest of my talk. Pre- and non-motor complications of Parkinson's. This is really, really challenging. And I told you earlier that loss of sense of smell and acting out your dreams can be 2 of the pre-motor symptoms of Parkinson's. Well, so can constipation. Constipation, unfortunately, is so common, it's almost like universal. But if you have had normal bowel movements your whole life and you turn 62 and all of a sudden you start noticing that, or maybe you turn 42, because the constipation actually can interfere with your bowels the way they work 15 to 20 years before you develop the symptoms of Parkinson's. So constipation can be a risk factor for developing Parkinson's. Depression, new onset depression. If you haven't been depressed your whole life and then all of a sudden you start struggling with, you just don't feel right, you don't feel good, you don't have energy, you don't have this, you don't have that. That and anxiety, those are 2 sides of the same coin. And if you come down with that later on in life, that's definitely a risk factor for developing Parkinson's disease. Low blood pressure on standing, that's that orthostatic hypotension. Believe it or not, we used to think that that was a sign of a different disease, a disease that mimicked Parkinson's. As it turns out, it can happen to any of us with Parkinson's, both before you have symptoms of Parkinson's and after you have symptoms of Parkinson's. And unfortunately, sometimes it's due to medications. Fatigue, apathy, pain. Before the diagnosis, the muscles can get so tight that you almost are willing to go get surgery done because of the stiffness and the soreness that you're experiencing. We've had patients go for rotator cuff surgery when all they needed was a little bit of levodopa, a little bit of WD-40 in the brain to get those muscles moving again. The muscles tighten up. And to top it all off, I wanted to say this, some of these can come and go during the day when your medicine is wearing off. So if you notice about 30 to 60 minutes before your next dose is due that you are feeling very anxious or feel very depressed, or maybe you've got severe pain in your leg or your buttocks or your shoulder, and then 60 minutes after you take your medicine, you don't have any anxiety, no depression, no aching in your muscles. That, ladies and gentlemen, is an on-off fluctuation of non-motor symptoms. I cannot emphasize this enough, because the key to treating that is not to give you a muscle relaxant or a pain medicine or something for depression and anxiety. It's to stabilize your dopamine levels, to help prevent those peaks and troughs. And you've got one of the world's best teams right here in front of you who knows how to do that. So you don't have to live with that. Slowed thinking. That's why Michael J. Fox always is in the dyskinetic state. He thinks faster than when he's in the slow state. It's very hard for him to think when he's in the slow state. Memory difficulties, urinary problems, bladder spasms. Again, this can be before you have Parkinson's, it can be after, it can be seen, it can actually be an effect of wearing off of your dopamine, where literally as your dopamine's wearing off, it's like, I gotta get to the bathroom now. And if you don't, sometimes the results are kind of catastrophic. Sexual problems, reduced sense of smell, sleep disturbances, we've talked about this before. These were the big three. Autonomic dysfunction. Autonomic just means automatic. There's different parts of our nervous system. There's a nervous system that we control, we think about, we move, we do things, we do that voluntarily. But there's another part of our nervous system that's completely unconscious, and that's the autonomic nervous system. It controls so many things: heart rate, blood pressure, sweating, bladder control, bowel control, did I mention blood pressure, heart rate, yes. How your pupils constrict. I mean, just everything and anything you could possibly imagine. So that autonomic nervous system we know is damaged in Parkinson's, and unfortunately it can cause more problems than just the simple stiffness, slowness, and shakiness of Parkinson's. This is a video of a guy who has the REM behavior disorder. Now, he's sound asleep. He's dreaming, but he's dreaming that he's being attacked. And boy, I'll tell you, he's going to give those guys a what for. He's going to make sure that they do not ever mess with him again. And he's telling them about it, and now he's going to show them what he's all about. I'm telling you guys, you get out of here, I'm going to beat the crap out of you, right there. And just think if you were sleeping next to this fellow. Boy, that would not be a fun way to wake up. And yet that can happen. The sensory symptoms, these are non-motor as well. Pain, I talked about the large muscle groups, numbness and tingling, burning and aching, abdominal pain, abdominal cramping. Can sometimes be a symptom of the Parkinson's, and sometimes if the dopamine is just right, it'll go away. It's kind of cool when that happens. I like that. I like you. You're a good guy. You're pretty cool. I like you, especially I like your shirt. Mine's the same color. Well, I got stripes, but you got blue. I got a blue one just like that one. That's really nice. I like that. Okay, loss of sense of smell, diplopia, double vision. Anybody in here with Parkinson's ever see double? How many other hands? Yeah. Anybody over here see double? Okay. That's not uncommon, because our eyes, in order to see a single object, when we're looking at a TV or reading a book or something, our eyes have to converge perfectly on that single item we're looking at. Well, with Parkinson's, unfortunately, the muscles get a little weak, especially when we get tired. And you end up seeing two images. They look blurry, they're hard to see. So you'll go to the ophthalmologist, they'll give you what? Prisms in your glasses. Well, the problem is that the divergence of the eyes varies from moment to moment and from day to day. I had one patient with 20 pairs of prisms, and he had to pick the one that best fit the way he was feeling at the time. I always say the best way to treat this is just take a quick cat nap. That usually takes care of the double vision, and when you wake up, the muscles and the nerve cells are all revived and everything. It usually works, but the other one that always works is you go over to your CVS or Rite Aid store and you get these little eye patches, and you put the patch over your eye, You get a big black hat with a feather sticking out of it, and you go, "Hi, matey. Ha ha. Who are we going to bandoozle today? Ha ha. Pirate. I'm a pirate." But the thing to remember is you got to move that patch from one eye to the other periodically, about every 30 to 60 minutes, so you don't end up with a lazy eye, a weak eye. Constipation, heart irregularities, blood pressure variability. Those of you who had your hands up where you said you stood up and you passed out, or you came close to passing out, this is becoming more and more common. Point. Almost all of our Parkinson's medicines can cause low blood pressure. So got to think about that. And there are a ton of other medicines out there that people take that can cause low blood pressure. The so Northera is one medicine that you can use, but there are simple things you can do. Remember those wedges we used to sleep? We used to lay on the floor, watch TV with that wedge pillow. You can put that right underneath your sheet. And if you sleep with your waist at the base of that waist pillow, your waist at the base of that wedge pillow, there I got it out, it will keep your body slightly elevated, the top half of your body slightly elevated all night long, and it does not allow the autonomic nervous system to get lazy overnight. It keeps it working. So in the morning, you're less likely to be lightheaded, which is a nice little trick. The other thing I like is have by your bedside when you get ready, because one of the reasons you're low blood pressure in the morning is you're dehydrated. You don't have a lot of salt in your system. You don't have a lot of fluid. Have a bottle of water and a small bag of potato chips. I mean, I think I'm the only doctor in the United States who prescribes potato chips for breakfast before you get out of bed. And it's great because it gives you a lot of salt, and there's no protein in it, so it doesn't interfere with your Parkinson's medications. And, you know, it may just be that difference that you need, just a little bag, not a big bag. I'm not talking about no family sack, you know. I'm just talking about the little 1 or 2 ouncer ones. And then bladder dysfunction, sweating, bladder dysfunction, sexual dysfunction, drooling, all of these, almost all of these can be affected by the lack of dopamine in the system. So if your dopamine is right, you're far less likely to have those sweating spells. My mother-in-law had Parkinson's for 40 years. She'd break out in this cold sweat overnight, and she'd just drench her bedclothes. Well, what I do, I just gave her something to carry her through the night, and sure enough, that sweating just went away, just like that. So anyway, those are the non-motor sleep disorders. There's a lot of these, excessive daytime sleepiness. Sometimes that's caused by the medications. Sometimes it's just caused by the Parkinson's. Sometimes you have trouble getting to sleep. Sometimes you act out your dreams. That's the REM behavior disorder. Restless legs, that's where you have trouble falling asleep because your legs are bothering you. And then when you fall asleep, you start jerking your legs so it wakes up your bed partner. Sleep apnea. All of you who have Parkinson's are at greater risk of developing sleep apnea than the general population. I'm sorry to have to tell you this, but it is very important, because if you're sleepy during the day, or somebody in your family, your spouse, your loved one, whoever's with you, says that you snore a lot and you stop breathing sometimes in the middle of the night, you need to be seen with a sleep study, because a lack of oxygen to the brain is bad for all of us, no matter when it happens, whether it's during the day, whether it's at night. Sleep apnea, I think, is an epidemic that's rampant in our country right now, and better to be checked and treated for it and not have it than have it and not be treated for it, because low oxygen, the brain does not like low oxygen any time of the day, and it happens many times during the night with people with sleep apnea. So the depression, anxiety, psychosis, dementia, apathy, and fatigue. Psychosis is something we're going to talk a little bit more about, but some people with Parkinson's will develop some cognitive changes. And the difference, I always tell people, you know, I would never want to have memory changes, never want to have thinking problems, but I'll tell you what, if I had to pick this over Alzheimer's, I'd pick this 100 times out of 100. And the reason for that is quite simple. I've never seen a person with Parkinson's and have trouble with their thinking forget their loved ones. I've never seen them in a situation where they literally cannot remember from one moment to the next what's happened. Now, it does happen, but that's in cases of delirium, which I'm going to talk about very briefly. But Alzheimer's robs you of your loved one, and it robs you of them permanently. It's just a shell. Those of you who know about Alzheimer's, my mother has it right now. She doesn't even remember who I am. Her firstborn. How could you ever forget that, ladies? I mean, tell me about it. It's no fun giving birth to a child, I guarantee you. Not the first time, I'm sure. I don't think we as men could ever handle that. Oh my gosh. Oh my God. I'm so glad God invented women to have children, not men, because there wouldn't be any children around the world, I guarantee you that. If it was up to us. Oh my gosh. Okay. Executive dysfunction. Hallucinations. Hallucinations can occur. That can be due to the medication. It can be due to the disease. It can be due to a combination. We've got treatments for that too. So there are medicines that actually increase the memory-enhancing chemicals in our brain. One's called acetylcholine. And these three medicines, they go by the names Aricept or donepezil, Exelon or rivastigmine, Razidine or galantamine. All of these can be used in Parkinson's to enhance memory. Only Exelon, rivastigmine, has been FDA approved to treat Parkinson's with dementia. But what's really exciting is that these medicines by themselves can simultaneously improve your memory and concentration, improve your depression and anxiety, take away hallucinations, give you more energy, more pep. It's just amazing how replacing one chemical, just like when we replace dopamine, we change people's lives. When we add this chemical back, that also changes people's lives. So sometimes you get a bunch of birds with one stone just by using something like this. And thank goodness all these are generic now. I did want to mention delirium. The bottom line is there's nothing about Parkinson's that changes rapidly. If you are thinking clearly, you're not having hallucinations, you're not confused, and then 2 days later you are out of your mind, and some doctor looks at you and says, oh, I checked your blood test, I checked your x-rays, I did a CAT scan and all that stuff. Oh, you must have just entered the rapid progressive phase of Parkinson's dementia. Oh my gosh, I feel so bad for you, sir. There's nothing I can do for you. Bullshit! I'm sorry. Did I say that? No, that was somebody. That was my evil twin. There is no rapid progressive phase of Parkinson's disease. If you change from being pretty close to normal to being out of your mind over a period of hours to days or even weeks, something else is going on. And that something else has to be found and corrected. It just doesn't happen. And this is where that Haldol thing comes in. Because doctors, to our shame, we have all been taught this for the last 30, maybe 10 billion years, back when I was in medical school and dinosaurs still roamed the earth. I mean, it's just like running away from Tyrannosaurus really kept me in good shape. I'm not as good a shape as this guy back here, but oh my gosh, back then I was. Whew. Okay, Haldol. Put on your list of allergies Haldol, H-A-L-D-O-L, H-A-L-D-O-L. Haldol is the most powerful antipsychotic drug ever invented, and it blocks dopamine more than you can ever imagine. You give it to a person with Parkinson's, they will turn into a statue, and they will stay a statue, not 4 minutes to hours, hours to days, days sometimes to weeks. It is so powerful. It is absolutely contraindicated. In fact, we were at this meeting with these nursing faculty, and there was a case of somebody, a friend of the teacher, the speaker, who had been given Haldol and died as a result of it. And that's what I want you to say. If somebody asks you, what, you're allergic to Haldol? What does it do? Cause a rash or something? You say, no, it could kill me. It could kill me. I've got Parkinson's, it could kill me. And then they say, well, where'd you hear that? I say, oh, some doctor, he was at a meeting, I can't remember his name, same old thing. Don't tell people who I am. But, when you say something can kill you, people will stand up and take attention, they'll pay attention to that, usually. But I got to tell you, it's just, I still hear cases of people with Parkinson's getting held on. It just drives me crazy. Okay, so there are medications that can cause delirium. Usually delirium is caused by something as simple as a bladder infection. You can have a bladder infection, you can start hallucinating, you can get out of your mind, and all you got to do is get the urine checked and get treated with the antibiotic that needs to be treated with. So bladder infections, pneumonia is probably the most common causes of delirium in Parkinson's disease. There are a lot of medications that can cause confusion and problems in Parkinson's disease. There are medicines that block hallucinations if you have them sort of as a part of your Parkinson's. The quetiapine and clozapine are the only two that we use on a regular basis. The problem with the second one is that you have to get blood tests, kind of like when you get blood tests for Coumadin. And then the new kid on the block, the new Plazid, is the only FDA treatment, FDA-approved treatment for hallucinations in Parkinson's. Got a lot of bad press recently. Said it was killing a bunch of people. Well, as it turned out, they looked back, and people with Parkinson's and hallucinations who were not on Nuplazid actually had a death rate that was twice that of the people who were on Nuplazid. Why would that be? Because so many of those people were probably going into nursing homes because of the hallucinations and the confusion. And the Nuplazid allowed them to stay home. So it actually saved lives. Half the death rate of people with Parkinson's with psychosis who were not on that medicine. And yet CNN made it sound like this was a life-threatening drug. Got to tell you, news, you got to really, really be careful what they say. So Parkinson's is not just about managing motor symptoms, the stiffness, slowness, shakiness, gait problems, balance problems. And you've got a wonderful, wonderful team here, interdisciplinary approach. We approach this as if you're a real human being. You know what? It's not just here, take a pill, this will make everything better. You've got to do the exercises, you've got to do the dancing, you've got to eat right, you've got to watch your bowel habits, you've got to sleep well, and make sure you eat that bag of potato chips when you wake up first thing in the morning, and get that little wedge bed thing. So anyway, so I am open to questions. Thank you so much for your attention and for your time. So grateful.